Welcome all to the today's session. So we will be discussing two talks. One is a headache in pregnancy, and this after this we will discuss another talk called which is a idiopathic intracranial hypertension in pregnancy. Okay, IIH. So these are the two talks which are related to headache that we are going to discuss. So in 90% of cases, it is a primary headache. Okay, generally the headache is divided into primary and secondary. In whatever headache which you will come across in pregnancy, 90% of cases it will be primary headache, that is either migraine or tension type of headache. But always rule out secondary or life-threatening causes. So neurological disease is the major cause for the maternal mortality. Headache may be only symptom of serious pathology, such as there may be CVT also, cerebral venous thrombosis, and that may present only as a headache. Okay, that is why we need to rule out the secondary causes. So primary examples are the migraine or the tension type, and that is the most common, the benign type of headache which you get. Secondary is more dangerous, and the preeclampsia, CVT, PRES, RCVS, IIH, that is benign intracranial hypertension. Okay, so that will have the high mortality. Okay, so now what are the red flag features? So if there is a sudden, severe or thunderclap type of headache, you have to think about two things: SAH, that is subarachnoid hemorrhage, and RCVS. Okay. Second is a new onset headache in pregnancy. That think about the secondary cause, whether there is a secondary cause for this particular headache. If there is a neurological deficit, think about CVT or stroke. Okay. If there are visual symptoms and papilledema, you will think about IH or raise ICP. Okay. Then seizures. It may be because of eclampsia or associated with PRES. Fever, may be possibility of infection, meningitis, etc. Change from a usual migraine, there is a possibility of the preeclampsia risk. Okay, because migraine patients are known to have the preeclampsia possibility. Okay, so red flag features for potential secondary headache. Okay, so what are the red flag features that we should always look for? This we have just discussed, that is the thunderclap headache, which is a rapid time to pick headache instantly in seconds. Okay, within seconds to minutes, this headache becomes worse, and it is generally associated with either subarachnoid hemorrhage, or you may be seeing this in other, that is the RCVS. Okay, so focal neurological symptoms such as limb weakness, aura less than 5 minutes or maybe more than 1 year, that is also one of the red flag we need to take into account. Then there may be non-focal neurological symptoms such as cognitive disturbance. So if there is a cognitive disturbance, always think of CVT. There may be central venous thrombosis. Okay, so change in the headache frequency, characteristics or associated symptoms, abnormal neurological examination, headache that changes with the posture, that is a sign of either high or low CSF pressure. Okay, so if there is a postural change, then think about these CSF pressure changes. Headache awakening the patient associated with migraine and raised intracranial pressure. Headache which is precipitated by physical exertion or Valsalva manure, consider subarachnoid hemorrhage or raised intracranial tension. Okay, then patients with risk factors for cerebral venous thrombosis, then think about CVT. Jaw claudication or visual disturbances generally associated with giant cell arteritis. So this is also a EMQ question. They will give you the scenario, and they may describe the will give the particular description, maybe thunderclap headache or how is the onset. Okay, and you will have to select the appropriate clause. So jaw claudication, visual disturbances, they are associated with giant cell arteritis. Generally, it is seen in women which are more than 50. Okay, fever, consider meningitis. If there is a neck stiffness, indicative of meningeal irritation. New onset of headache in a patient with history of HIV infection, and new onset of headache in a patient with previous history of cancer. Okay, so you need to know these symptoms well. So when you are evaluating a case with headache, you should always ask for the onset, whether it is a sudden or gradual onset. What is the severity, duration, and frequency? Any previous migraine history we need to know. what is the relation to the pregnancy? Associated symptoms such as visual disturbance, vomiting, seizure. Always ask, is this the different from your usual headache? Okay, this question you can ask, and then the patient will give you the description. Then investigations you should do fundoscopy. If there is a papilledema, that will suggest you of increased intracranial pressure. Then cranial nerves, diplopia or sixth nerve palsy. Think of CVT or IIH. Okay, cerebral venous thrombosis or benign intracranial hypertension. Okay, then motor, if there are UMN signs, what is the gait of the patient, cerebral involvement, obstetrics such as blood pressure, proteinuria, clonus, that you need to look into it. Always rule out preeclampsia after 20 weeks of gestation. Look at the gestational age, what is given. Okay, then this blood pressure, proteinuria, clonus, that also you need to find out from the scenario and then make an appropriate diagnosis. Now we will see the individual condition. Now migraine. What is the typical nature of this migraine headache? Generally, it is unilateral, pulsating, associated with nausea, photophobia. It will improve, okay, during the pregnancy. It may be without aura also. So in pregnancy, there may not be typical aura in migraine. Okay. If there is aura, it may be visual or it may be in form of scotoma or some sensory aura can be there. And there is a unique pregnancy point. Aura may occur without headache also. Okay. So what is the treatment for migraine during the pregnancy? The first line is a paracetamol plus antiemetics. NSAIDs can be used, but they have to be avoided in the third trimester. Then safer drug is a sumatriptan. It is safe, but it is a reserve. Okay. Prophylaxis. Propranolol is the first choice for the prophylaxis. The other is a amitriptyline. So what are the important risks? There is a 2 times risk of preeclampsia in the patients who have migraine, and there is a 17 times risk of stroke in patients who have the migraine. So migraine, there is a risk of preeclampsia, which is increased, double risk of preeclampsia, and stroke risk is increased by 17-fold. Okay. Now, second is a preeclampsia. So preeclampsia, you need to see the blood pressure, the proteinuria, the clonus that you need to know. You need to correlate the history of headache when it actually started. So headache in a woman who is pregnant or in the puerperium, fulfilling the criteria C. Okay. Then B is a preeclampsia or eclampsia has been diagnosed. If she is already diagnosed preeclampsia or eclampsia, the criteria C is evidence of caution demonstrated by at least 2 of the following. The headache has developed in temporal relation to the onset of preeclampsia or eclampsia. Okay. And either or both the following, that is headache has significantly worsened in parallel with the worsening of the preeclampsia or eclampsia, and headache has significantly improved or resolved in parallel with the improvement or resolution of the preeclampsia eclampsia. So that they want to say there is a temporal relationship of the headache with the eclampsia. So if the eclampsia has worsened, the headache has also worsened. If the preeclampsia has improved, the headache has also been improved. So that kind of temporal association you will see. Then headache has at least 2 of the following 3 characteristics. Generally, it is bilateral, pulsating quality, and aggravated by the physical activity. So these are the 3 criteria for diagnostic criteria for headache, which is attributed to the preeclampsia or eclampsia. Okay, so these criteria you should know, that headache in a woman who is pregnant or in puerperium, and she should fulfill these criteria which are mentioned in the criteria number C. Okay. Or she can be either diagnosed case of preeclampsia or eclampsia, and this headache has got a temporal association, either improvement or worsening, which is in correlation with the preeclampsia, eclampsia, and typical nature of the headache, that is bilateral location, pulsating quality, and aggravated by physical activity. Okay. So this headache, which is associated with preeclampsia, generally will be after 20 weeks of gestation or maybe in postpartum period, bilateral, pulsating, blood pressure will be raised, there will be proteinuria. Okay. So you need to have at least 2 or more criteria, such as temporal relation with the preeclampsia, worsening or improvement of the disease, and it is bilateral, pulsating, or worse with activity. Most common prodrome before the seizure. Okay. Then PRES. posterior reversible encephalopathy syndrome. PRES, posterior reversible encephalopathy syndrome. This is the CT picture of this patient. Okay. Generally, it is seen in severe preeclampsia patient. There will be headache, seizure, visual loss, and confusion. Okay. So, cognitive symptom will also be there if there is a PRES. Okay. So primarily, if it is only preeclampsia, you may not have the cognitive feature. Cognitive feature will also be present in CVT. Okay. So very careful reading of the scenario is required. Okay. So now we are discussing about CVT. Generally, there will be severe preeclampsia, there will be headache, seizure, visual loss, confusion. Pathology is it is a vasogenic edema. Generally, the posterior region of the brain is getting affected, and you have to treat this as a severe preeclampsia, control the blood pressure, magnesium sulfate may be required, and the delivery may be required. So here is this is the plane at which this image is taken, and here the posterior region of the brain is getting affected. Okay, so this is the figure. Then next is the CVT, cerebral venous thrombosis. Okay, it is rare but catastrophic cause of headache. So pregnancy, we know that it is a prothrombotic state. It may be presenting with isolated as a headache, and it becomes a diagnostic challenge. Important cause of maternal morbidity and mortality. So incidence is around 1 in 2,500 to 1 in 10,000 deliveries. Generally, it is seen in the third trimester or first 4 weeks postpartum. First trimester, it is rare but still possible, but more common in the third trimester or the first 4 weeks of the postpartum. Then what are the risk factors? Pregnancy, which is a hypercoagulable state, dehydration, cesarean section, systemic infection, vomiting, anemia, etc. Okay. The common sites are the superior sagittal sinus, that is the commonest. The next is the cortical veins. Okay. Clinically, what you will get, there will be headache. This is seen in around 80 to 90% of cases. There is no specific pattern, but generally acute or subacute, localized and continuous type of headache. Generally, it is a moderate to severe in intensity and may be the only symptom. So rarely you may get the headache as a persistent headache, but you have to correlate with the scenario that the patient is in the third trimester or early puerperium, and these risk factors you will always think of the this CVT, and there may be symptom which are cognitive in nature. Okay. So associated features will be papilledema. There is increased intracranial pressure, seizure because of the cortical irritation, focal deficit maybe because of venous infarction, altered consciousness seen in severe disease. There may be diplopia or sixth nerve palsy, raised intracranial pressure. Psychosis is rare, but it has been reported. So symptoms may evolve over hours, days, or weeks also. Okay. Now coming to the diagnosis. Imaging modalities. CT brain has got a lower sensitivity, only 30% sensitivity is there. But it is a initial test. It is the status is the initial test you can do CT brain plain, but the preferred will be the MRI brain. It will detect the lesion, and it is better than the CT. And the most gold standard is the MR venography, MRV. So MRI with MRV is the preferred for CVT. It shows the venous thrombosis. Okay, so this can be asked in the SBA. If there is they may give you the CT finding. CT is normal, but that is not a gold standard investigation. Still, there can be CVT. So think of CVT on the clinical features and don't go only on the normal CT report because it has got a low sensitivity. Okay, so gold standard investigation is a MR venography. Now coming to the management. Management, it will require urgent neurology referral, start treatment without delay. The treatment of choice is a LMWH. Okay, that is the first line, low molecular weight heparin, and it is to be given for 6 months. Okay, in severe cases, there may be neurological deterioration or coma, and endovascular therapy may be required. So you have to follow up with imaging. Again, you will have to repeat MRV at 3 to 6 months and just to look whether there is a recanalization or not. Now, what is the prognosis? Pregnancy-related CVT has got a better prognosis and mortality is less than the non-pregnancy CVT. Okay. What is the future pregnancy counseling in these patients? Future pregnancy is not contraindicated. Recurrence is possible. Prevention LMWH prophylaxis antenatal plus postpartum in these patients. Okay. Now you have to consider the hematology referral and investigate for thrombophilia for these particular patients with CVT. Coming to the imaging and referral in pregnancy, in general, what you should do, imaging should not be withheld. Okay, even in pregnancy, you should carry out the imaging. Okay, CT head, it can be performed. There is a very low fetal radiation with CT scan. When you do the CT head, there is a very low fetal radiation. What about MRI? MRI is preferred, but it is to be avoided in the first trimester as far as possible. And with specialist input, neurological opinion should be available 24/7. From SBA and EMQ point of view, you should remember that headache with normal CT, still there is a possibility of CVT. Headache plus 6th nerve palsy, there is a diplopia. It may be because of the increase in intracranial pressure and also maybe because of CVT. Postpartum, there is a headache, there may be seizures. So CVT is one diagnosis, may be associated with preeclampsia also. Okay. Only headache in pregnancy, do not miss CVT. And best diagnostic test for CVT is MRV. Okay. So summary, most common symptom is headache in 80 to 90% of cases. Best is MRI plus MRV. CT is normal in 70% of cases. Treatment is LMWH for 6 months. Risk period is a third trimester and postpartum. Future pregnancy is allowed and prophylaxis will be required. Okay. So risk period is third trimester and postpartum. Risk factors are the cesarean section, dehydration, infection, anemia. So headache is present in 80 to 90% of cases, and in fact, sometimes it may be the sole symptom. Okay, nature will be variable. Associated features will be papilledema, seizures, focal deficit, diplopia, 6th nerve palsy. Also, you should keep in mind. So if there is a diplopia, 6th nerve palsy, one of the diagnoses is the CVT. CT often normal, MRI plus MRV is the gold standard. Okay. So here you can see the venous thrombosis. Again, the CT image is taken at this plane. So treatment is LMWH, follow-up is MRV at 3 to 6 months. Next is a postpartum, this RCVS. Okay. So this is seen most commonly postpartum. Generally, the presentation as a headache with recurrent thunderclap type of headache. Diagnosis is made by the angiography, and typically what you see is the arterial bleeding. Okay, arterial bleeding you see. Management is a calcium channel blockers, magnesium sulfate, and steroids. Okay, post next differential diagnosis is a post-dural puncture headache, that is PDPH. This is also can be asked in the EMQ. There is a puncture of the dura which occurs around 0.5 to 2.5% of cases. So these also figure you should remember for SBA point of view. Dural puncture, what is the prevalence of the dural puncture is around 0.5 to 2.5% of cases. But when there is a dural puncture, in that particular case, what is the chance? It is 70 to 80% chance of post-dural puncture headache. The chance of dural puncture is less. But if there is a dural puncture, there is a 70 to 80% chance of developing PDPH. So if accidental dural puncture occurs with epidural needle, there is a 70 to 80% chance of post-dural puncture headache. The headache is usually in the front occipital region and radius to the neck. It is characteristically worse on standing and typically develops 24 to 48 hours after the post-puncture. Conservative management includes hydration and simple analgesics. Untreated, the headache typically lasts for 7 to 10 days, but it can last up to 6 weeks also. Epidural blood patch is the treatment and 60 to 90% cure rate. So treatment is a epidural blood patch and the efficacy is around 60 to 90%. Okay, so that is PDPH or the post-dural puncture headache. So important thing is a CSF leak following dural puncture is the etiology. It is seen after the spinal anesthesia and accidental dural puncture during the epidural. The prevalence is around 0.5 to 2.5%. But if there is accidental dural puncture, 70 to 80% chance of developing the headache. Then location is a fronto-occipital. It radiates to the neck. Generally, there is a postural association. It will develop 24 to 48 hours post-procedure. It is worse on standing and improves on lying flat. So if these things are present in the scenario, think of PDPH. Okay. So postural headache after epidural spinal, think of PDPH. Associated, there will be neck stiffness, nausea, photophobia, but these will be less prominent than the migraine. Okay. Treatment is conservative, hydration, simple analgesics, and caffeine. Generally, it results in 7 to 10 days. Okay. The definitive treatment is an epidural blood patch, which is effective in 70 to 90% cure rate with the epidural blood patch. Okay. So take home message is that headache after epidural or spinal and postural, think of PDPH. It will improve on lying down. Differentiate that will differentiate from CVT and press. The first line treatment is a conservative, not immediate imaging. Persistent severe treatment is a blood patch, which is effective in 80 to 90% of cases. Okay. How to differentiate from CVT? Okay, so PDPH and CVT. How will you differentiate? In PDPH, you will have a typical history of the procedure which is being performed, that is the spinal epidural. CVT can happen anytime, especially the postpartum or the third trimester. PDPH has got a postural presentation that has not significant with CVT. Neurological deficit will be absent in PDPH. There may be neurological deficit which is common. Imaging is not required initially, but MRV will be required in CVT. Treatment is with blood patch in PDPH, and it will be LMWH in CVT. Okay. Now next is the idiopathic intracranial hypertension. We will have little discussion here, but there is a separate talk on IIH that we will go into the detail. Okay. So idiopathic intracranial hypertension, the typically it is seen in obese women. Headache is generalized, worse on straining. Typically, there will be papilledema and the visual loss. CSF pressure will be more than 20 centimeters of water. The advice is, or the management will include the weight control, acetazolamide, and therapeutic lumbar puncture. So these are the modalities of the treatment. Now coming to the imaging in pregnancy, CT head can be performed. It is safe. There is a very low risk of fetal dose radiation, that is less than 0.005 milligray. Okay. Then MRI, avoid in the first trimester. Ionotrated contrast to be avoided. Check neonatal thyroid if the ionotrated contrast is given. Gadolinium can be used. It appears safe during the pregnancy. Then breastfeeding can be continued after the contrast. So never withhold imaging because of the pregnancy. Okay. So important points from the SBA point of view will be headache plus hypertension plus proteinuria. Think of preeclampsia, headache plus seizure plus visual symptom. You may think about the praise also. Then headache only. That may be the presentation of CVT, postpartum thunderclap, RCVS, papilledema, and obese patients. It may be related to the IIH. Okay, and aura without headache in pregnancy is one of the migraine variant also. Okay, so when you are solving the SBAs and EMQs, you should think about this particular approach of the symptomatology and the various flag signs which are given to you. Severe hypertension, headache, visual symptoms, preeclampsia and eclampsia, as well as press. Postpartum recurrent thunderclap, RCVS, headache plus focal deficit plus normal CT, CVT, obese, there is a papilledema, visual loss, IIH, and typical unilateral pulsatile headache, migraine. Okay. So when you are reading the scenario, think whether it is a primary or secondary. Any red flags which are given. Look for the blood pressure and the urine examination. Look for the neurological examination findings and low threshold for the imaging. These are the important things. Now we have certain EMQs on this particular topic. Doctor, can you please go through these EMQs? We have 4 or 5 EMQs and then we'll see the answer. Doctor?
Yes, sir.
I'll show you. Yeah.
A 28-year-old primigravida at 34 weeks presents with severe headache for 2 days. She describes it as bilateral throbbing associated with visual blurring and nausea. On examination, BP is 160-110 mmHg. Urine shows 2 plus protein. Reflexes are brisk with clonus. No focal neurological deficit is noted.
Okay.
So options.
Yeah.
A pre-eclampsia.
Okay. Are you sure preeclampsia only? So you are which parameters you are labeling?
There is rice BP, sir, proteinuria,
Yeah.
with bilateral throbbing headache.
And no focal neurological
No
deficit.
focal
But you
neurological
have to
deficit,
think
no
about
seizures.
34 weeks of gestation. Okay. If there is a BMI which is given, okay, is there any postural association? Okay. The nature of
Yes.
the headache. Okay. We have seen the criteria to label that as a preeclampsia. That typically mentions the bilateral nature. Okay. Okay. That is why we are putting this under the heading of preeclampsia. Is that right?
Yes, sir.
Okay. Next.
30-year-old woman, day 5 postpartum, presents with recurrent episodes of sudden severe thunderclap headaches over last 3 days. Each episode reaches the peak intensity within seconds and associated with nausea and photophobia. CT scan is normal. There is no focal neurological deficits.
So what is the scenario? Day 5 postpartum,
It
recurrent
is
episode.
mostly RC. Yes.
So option
RCVS. E. Reversible
E,
cerebral
reversible
vasoconstriction.
cerebral vasoconstriction syndrome. Reversible cerebral vasoconstriction syndrome. Most likely it appears that because it is a thunderclap in nature. The other is a subarachnoid hemorrhage that will also present as a sudden or thunderclap will be the description which is given. But subarachnoid will have other parameters also. Generally, the patient may be hypertensive in that particular case. Okay, and the scenario will be little different.
Yes.
Next.
A 26-year-old obese woman at 20 weeks gestation presents with persistent generalized headache, worse on coughing and bending. She reports transient visual obscurations and double vision. Examination reveals papilledema and sixth nerve palsy. It is a idiopathic intracranial hypertension.
Yeah, IIH. Okay. Next.
A 32-year-old woman, 2 weeks postpartum, presents with progressive headache over 3 days. The headache is continuous and moderate to severe. She develops confusion, focal right-sided weakness. CT brain is normal. So this can be CBT.
Yes, typical picture of CBT. Okay, so the option here will be
D.
option D. And previous one was I, idiopathic intracranial hypertension. Okay.
A 25-year-old woman at 16 weeks gestation presents with recurrent unilateral pulsatile headaches associated with nausea and photophobia. She reports seeing zigzag lines and flashing lights before the headache starts. Neurological examination is normal. This is migraine with aura.
Yeah. Yes. So this is G, migraine with aura. Okay. So let us see the answers. First was a preeclampsia, right? Second was RCBS. Third was IIH. Fourth was CBT, and sixth was migraine with aura. Next, we have certain SBS, doctor.
Yes, sir. A 29-year-old pregnant woman presents with mild bilateral band-like headache. It is not associated with nausea, vomiting, or visual symptoms. Examination is normal. Most likely A migraine, B tension type headache, C CVT, D IH, E press. It is B tension type headache.
Correct. Band-like headache or the tension. This band-like is very typical for this tension headache. Okay.
Yes, sir.
Next.
A postpartum woman presents with headache and focal neurological deficit. CT brain is normal, but suspicion of CVT remains high. What is the best investigation? A. CT angiography, B. lumbar puncture, C. MRI with MR venography, D. EEG, E. skull X-ray. It is C. MRI with MR venography.
Yes. So when you are suspecting CVT, it is MRI
CVT.
with MR venography. Okay. Next.
A 27-year-old woman develops a headache 2 days after epidural anesthesia. The headache is worse on standing. It is relieved by lying down. Most appropriate management: A. Immediate CT scan, B. LMWH, C. Epidural blood patch, D. Magnesium sulfate, E. Propranolol, C. Epidural blood patch.
Correct. Now, what is the effectiveness of this?
60%.
60 to 90%.
90%.
Okay, 60 to 90%.
60 to 90%.
And what is the prevalence of this dural puncture?
80 to 90%.
No.
70 to 80%.
Prevalence of dural puncture.
0.5 to 2.5%.
2.5%. But it happens. Then the risk of PDPH is
70 to 80%.
Okay, and this epidural patch is effective in 60 to 90%.
60 to 90%.
Very clear numerical question also.
Yes, sir.
Yeah, next.
A pregnant woman presents with severe migraine, not responding to paracetamol. Which drug has best safety evidence for acute treatment? A. Ergotamine, B. Sumatriptan, C. Valproate, D. Topiramate, E. Morphine.
Severe migraine, not responding to paracetamol.
B. Sumatriptan.
Yes, triptans are safe. Okay, during pregnancy you can use, but it is a reserved drug. Okay. Next.
A 32-week pregnant woman presents with new onset headache and visual disturbances. Most important initial investigation: A. MRI brain, B. CT scan, D. blood pressure measurement and urine protein, D. lumbar puncture and EEG, C. blood pressure measurement and urine protein.
Yes, it is the initial investigation and she's 32 weeks. Okay, and it is a new onset headache. So you will first think of preeclampsia. So blood pressure measurement and urine protein. Next.
Yes. A 30-year-old woman at 32 weeks presents with sudden severe headache, visual disturbances, and vomiting with BP 170-110. Most likely diagnosis is A. Migraine, B. Pretension headache, C. Pre-eclampsia, D. CVT, E. sinusitis, C. Pre-eclampsia.
Yes. So new onset headache, hypertension, visual symptom. It is a classic. Always first rule out preeclampsia after 20 weeks of gestation. Next question.
Postpartum woman presents with headache and focal neurological deficit. CT brain is normal. Next best step: reassure, lumbar puncture, C. MRI with MRV, D. EEG, E. start antibiotics, C. MRI with MRV.
Yes.
To rule out
Because only,
CVT.
yeah, 30% sensitivity. Okay. CT is normal in 70% of CVT cases. So MRI with MRV is the gold standard. Next.
A woman develops headache 48 hours after epidural. It worsens or standing and improves when lying flat. Diagnosis: A. CVT, B. migraine, C. PDPH, D. IIH, E. press. It is C. PDPH.
Yes, PDPH, very typical. It is a postural association and there is a history of 48 hours prior, there was an epidural which was given. Okay, so postural headache plus recent epidural, diagnostic. Next.
A pregnant woman has visual zigzag lines followed by unilateral headache with nausea. Diagnosis: A. tension headache, B. migraine with aura, C. IIH, D. CVT, E. press. It is B. migraine with aura.
Yes, so migraine with aura is reversible neurological symptom, generally visual before headache. Okay. Next.
A 28-year-old obese pregnant woman has headache, worse on coughing and visual blurring. Fundoscopy shows papilledema. Most likely diagnosis: A. migraine, B. CVT, C. IH, D. RCVS, E. tension headache. IH, CIH.
Yes, obese and headache worse
Papilledema.
on coughing, visual blurring. So association with the increased intracranial pressure, fundoscopy showing papilledema. So all these features will be suggestive of IIH. What is the treatment of IIH? What is the treatment of IIH?
IH.
Acetazolamide.
Therapeutic lumbar puncture.
That is first you will try with
Acetazolamide.
conservative. Okay.
Yes.
Acetazolamide. So obesity
Acetazolamide.
plus papilledema, positional headache is IIH. Next.
A woman presents 1 week postpartum with recurrent thunderclap headache. CT is normal. Most likely diagnosis: A. CVT, B. RCVS, C. migraine, D. IIH, E. PDPH. It is B. RCVS.
Because it is a recurrent thunderclap
Recurrent
headache.
thunderclap headaches.
Yeah, recurrent thunderclap.
A pregnant woman presents with migraine. First line treatment: A. sumatriptan, B. NSAID, C. paracetamol, D. propranolol, E. morphine. It is paracetamol. C. paracetamol.
Yes, first line is a paracetamol. Okay. Next.
Diagnosis of CVT is confirmed in a pregnant woman. Best treatment: A. Aspirin, B. Low molecular weight heparin, C. Warfarin, D. Thrombolysis first line, E. Steroids. It is low molecular weight heparin. B.
Yes. CVT, the first line is a LMWH is the first
For
line
6
treatment
months.
even in pregnancy and continue for 6 months. Next.
A pregnant woman requires imaging for suspected intracranial pathology. Which statement is correct? CT is contraindicated. MRI is unsafe in all trimesters. Imaging should be avoided. CT head has minimal fetal radiation. E contrast always safe. D CT has a minimal fetal radiation.
Yeah, CT head has got a minimal fetal radiation. Okay, CT head is okay. CT head fetal dose is extremely low, never without imaging in pregnancy. Next.
A pregnant woman has a headache attributed to preeclampsia. Which feature supports this diagnosis? A. Unilateral pain. B. Improves with sleep. C. Associated with hypertension. D. Occurs only postpartum. E. Always with aura. It is C. Associated with hypertension.
Correct. So this is associated with hypertension. That is the key feature. There is a
Temporal
temporal relation with
relation with
hypertension and
hypertension,
proteinuria.
proteinuria.
Okay. So take home message: postural headache, PDPH, thunderclap, RCVH, and SAH. Okay. Normal CT plus still there is deficit, then CVT, papilledema plus obesity, IH, hypertension plus headache, preeclampsia. First line migraine treatment is a paracetamol. Okay. So that finishes this headache in pregnancy talk.